So thank you for inviting me to talk, and I share the sentiment. I wish we were all together. This has been tough, both personally and professionally, so I recognize that. So I'm going to talk today really about a hodgepodge of things that are all related, but I'm going to start with, for the newer families on the call, the reasoning behind how and why we do MRI surveillance the way we do it, and then give some updates on some of our research in the early natural history of cerebral ALD. As Molly was saying, newborn screening has afforded us a new opportunity to study the early stages of disease, and we're in the active phase of that. But it takes some time to really kind of understand how disease evolves early on. So I'm going to talk a little bit about what we know. Let's see if this will work. Here we go. So we're going to talk about, in general, what we know about CCALD natural history. In newborn screening, you're identified with elevated very long chain fatty acids and a mutation in ABCD1. And if you meet the diagnostic cutoffs for the newborn screening labs, you're referred to a metabolic geneticist who is required then to confirm the diagnosis of ALD. And what we know is, for the most part, 60 to 70% of boys identified won't have cerebral ALD. They'll go off into adulthood, half of whom before the age of 10 will develop adrenal insufficiency, and then over time experience increasing risk for AMN. We do know that 30 to 40% of boys, for I don't want to say unknown reasons, because this is under active investigation by multiple researchers in the field, and multiple approaches provide some insight as to why some kids develop cerebral ALD. But what we know is some small portion of those patients who develop a cerebral lesion, it'll spontaneously stop on its own and it won't contrast enhance. But for the most part, the majority of patients are at risk for progressive disease. And so a lot of people have seen these slides and know the published natural history. Cerebral ALD is a bad phenotype. If we transplant patients while they're symptomatic, they'll survive, but they'll unfortunately develop, vast majority will develop major functional disabilities over time. Of course, the point for newborn screening is to move that curve so that patients not only survive, but we maximize their neurologic function by intervening as early as possible. So what are the signs of early stage cerebral ALD? This is some work that we published a couple of years ago now, but when undergoing MRI surveillance, what we're looking for are these tiny changes that occur 85% of the time in the splenium and the corpus callosum. 10 to 15% of the time they'll present in the genu of the corpus callosum, which is sort of the body of crossing fibers, but more frontally. And Dr. Pierpont spoke about this a little bit yesterday, looking at posterior versus frontal variants of cerebral ALD. So this is what we're looking for in MRI screening. Really subtle changes here. Again, in the splenium, here in the genu. Rarely, but it does occur, some boys will develop their cerebral ALD in the corticospinal tracts, so in the brainstem. And then all the way, this column all the way here on the right just shows the subtle contrast enhancement that we're looking for that tells us that the disease is active. So we set off to answer the question, when does childhood cerebral ALD develop? We know historically when it develops, but we wanted to really quantify it and get a good idea so it can help inform how we do our MRIs. So we know that after patients are identified, at some point the lesion develops, and we know that in general the lesions precede symptom onset. So there's this pre-symptomatic time period, and then obviously after symptoms develop, there's a symptomatic time period. And these are just the survival curves, showing that, of course, when we intervene after lesion onset, but before the development of clinically apparent symptoms, we can maximize function and survival, which is what we want to do. Because there's no known at this point one-to-one genotype-phenotype relationship, we're relegated to doing MRI screening, where we take a series of photos every couple of months of the boys' brains, try to detect the lesion as early as possible, and then get them into referral. So this is the ultimate goal for MRI screening for cerebral ALD. So this year we were able to, oh gosh, never mind. At the end of last year, this paper is a year old already. Time is flying. We published guidelines informed by a meta-analysis. That work was done by, some of you may remember Helena Yan. She was our research program coordinator, who's since gone off to medical school, and then Bella Turk, who works at the KKI. And we identified 123 studies of boys that included boys with cerebral ALD. It's about 1,300 patients. And then we pulled individual data from about 350 patients. And really what we found was 90% of the cases are diagnosed between 3 and 12 with a median age of 7. Now, this is important. The data that went into this search were asymptomatic cases and early symptomatic cases. So there are symptomatic patients in here because before newborn screening, patients were diagnosed when they showed up to the doctor's office with attention difficulty and visual symptoms, and they had parietal occipital white matter disease on MRI. So knowing this, that between the age of 3 and 12, we developed the MRI screening guidelines, which were published in the JIMD, and they put together this nice visual abstract for us. So our recommendations are attain an MRI between 12 and 18 months old. The reason for the reference range was when we initially talked about putting together surveillance guidelines at this meeting, now I guess 3 or 4 years ago, one of the suggestions from the families were this is going to be complicated, a lot's happening. Is there any leeway into getting educated and then sort of setting up the first scan? The first scan really serves as a baseline to understand the underlying brain anatomy of the patient. Step 2 is then to obtain a second MRI in the second year of life. And I'll talk about why that is in a second. And then really between the ages of 3 and 12, obtain a contrast enhanced MRI scan every 6 months. Because we know that's the time of highest incidence. And then after 12, you can obtain an annual MRI, but the recommendations will vary depending on whether you developed a lesion or not. So this is a lot. It's a tough surveillance schedule to follow, but I will say families successfully follow it. There are ways to decrease the time under anesthesia and to decrease the exposure to contrast agents over time. So what we do at Cornell is we do something called real-time reading. Not every institution can do this. This takes a bit of orchestration, but what happens is the boys go into the scanner, and at least at our institution, we have them do the first half of the scan, and then they notify a neuroradiologist who's sitting at the computer reading the scan as it's being obtained. And if they see any abnormalities, they will then give the patient gadolinium to see if the lesion lights up or not, to tell us whether it's active or not. But if they don't see anything, we pull the kid out of the scanner. So what that does is it limits the amount of time you're in the scan. And if you don't need gadolinium at that point in time, we don't administer it. There are what we call child life programs. So the one at Cornell is called MRI, I Am a Hero, and child life specialists work with the boys to teach them about MRIs, make it fun. Oftentimes you actually have to sedate patients using anesthesia to stay still for an MRI scan up until about 7 or 8 years old. We've been successful in graduating boys off sedation at around 4.5, 5 years old. So saving them a lot of anesthesia exposure. And one of the ways they do that is using movie goggles. So this is what an MRI scan looks like through the goggles for one of our patients. I have permission to show that. Okay, so those are sort of the nitty gritty around disease surveillance. So we want to do better. So we asked the question then, and this was one of the comments from one of our reviewers from the initial paper. Well, when does presymptomatic childhood cerebral ALD develop? Why don't you just analyze all the cases before they had symptoms, which is the right thing to do. And so as Molly had mentioned, guidelines are good for the state of knowledge at the time, with the expectation that the guidelines will be revamped and revisited every 5 to 7 years as we learn more. And so we asked the question, well, okay, well, when does presymptomatic childhood cerebral ALD develop, and how long is the presymptomatic or therapeutic window of opportunity? What we're essentially asking is, how long is this? We're going to say that nobody is going to do the study where we identify a boy on newborn screening and then just wait till that kid develops symptoms. That's not going to happen. So one thing we can do is go back into the literature, look at the presymptomatic cases and quantify and sort of approximate this timeline to give us an understanding about how long do we really have to transplant the patients, and when do we expect things like gadolinium to show up. So this was work, collaborative work that's, it's not published, it's under review, it's submitted. This is a really nice graphic put together by Keith Van Haren, who's a co-author on the paper, and I thank him for his work. So we asked really 3 basic questions. At what age do asymptomatic lesions first appear? Question 2, from the time you have an appearance on MRI of a lesion, how long does it take for that lesion to develop that little blush of contrast enhancement that we spoke about? And then from the time that you develop that blush of enhancement, how long does it take to get the patients to transplant? So we looked at 71 cases of this and that were pooled data between multiple institutions. So for the pre-symptomatic cases, we found that the median age was 6.4 years old. Youngest kid was 2, oldest kid was 12. And they had an initial LES score of 1.5. So that's just a calculated LES score. So really 0.6 years, about a half a year earlier, the curve gets shifted about a half a year earlier than your mixed asymptomatic and symptomatic cases, which makes sense. You're detecting patients earlier. So from the time that you detect a lesion on the T2 MRI, how long does it take for enhancement to develop? What we found was half the patients had enhancement at diagnosis. So when they had their initial lesion, there was evidence that there was blood-brain barrier breakdown. The other half of patients had a T2 lesion, which was small, had a median LES score of 1.5, but it didn't enhance. So you had to take pictures really kind of rapidly thereafter to follow to see when that blood-brain barrier gadolinium enhancement developed. And we found that in the other half of patients where they didn't have enhancement at diagnosis, it showed up 6 months later. 81% of the patients developed evidence of lesional enhancement by 18 months, but it's really stacked in the first, at least half are stacked in the first 6 months. So that's all comers. Those are all the patients in the data set. So the last question was, okay, from the time that enhancement showed up, how long did it take traditionally to treat the patients? So time from enhancement to treatment, we have data for 43 patients. Half of the patients were treated by 3.8 months. All patients were treated by 14.9. And of the data that we have of the patients where we have clinical data at their treatment date, almost 96% of them were asymptomatic. So it tells us, at least traditionally, that boys from the time that they had their first enhancing lesion, they were treated within 4 months. And that got better over time. I didn't show that data, but our ability to get patients from their diagnostic MRI of inflammatory cerebral ALD to treatment got better over the years. And that's because of newborn screening, more is known about the disease. the fact that the ALD Alliance exists and is telling everybody about this. So, there's the physicians are getting better at this. Boys are also worked up now in parallel from the time that they develop a cerebral lesion, and even beforehand, through family history, for possible transplant. So that's the whole cohort. We did a subset analysis and looked at the boys who had a diagnostic LS score less than or equal to 1, so really the smallest of the smallest lesions. And the reason we did that is because of Dr. Pierpont's work showing that the boys need the best outcomes happen when the boys are treated before a LS score of 2. So, time from lesion to enhancement, if you had a small lesion, it was detected at a median of 4.7 months. So half the patients were detected by 4.7 months. 94% of the patients by a year and a half. But again, really stacked in that first year. So the guidance here is if you develop a cerebral lesion and you have a early stage disease, the physicians should expect to see about half of those cases develop enhancement between 4 and 6 months, and with the majority by a year, and really the vast majority by a year and a half. And then from enhancement to treatment, the number didn't change. Interestingly, and this is a big caveat in statistics, they tell you not to interpret too heavily the tails of a natural history curve, and I echo that, but we do report that of the boys with a diagnostic LS score of less than or equal to 1, all of them were treated by 12.7 months, and all of them were asymptomatic at treatment. That is not to say that you should wait a year to treat the patients. You should still treat them as early as possible. I didn't show the data here, but if we look at the whole data set from the first abnormal scan, take the enhancement piece out of it, but the first abnormal scan to treatment, across the whole data set, boys were treated, I think the median time was like 7-point-something months. So all of this is meant to give you a feel for how fast the patients need to, how fast the physicians need to move. We have this term in neurology. It's in stroke neurology, and it's door to needle time. So if you have a stroke, how fast from the time you hit the door of the hospital to getting an intervention to dissolve the needle. This is kind of corollary to that time from first lesion enhancement and then to treatment. But what this will help do is help us over time figure out how to optimize some of our surveillance guidelines. And then we hope it can provide some benchmarks for some future clinical trials. I didn't put the slide in, but there are efforts now funded by the GLIA consortium, for which I'm working with them on that, for developing a data extraction tool so that we can pull this sort of data and standardize it across clinics and pull this sort of data as we follow patients into the future to help further refine what we do. And then one last update I want to give, which is exciting, is 2 years ago from this very meeting, Stefan Kemp invited me to collaborate with him on publishing the ALD, what used to be called the mutation database, but as of I think yesterday we call it it has been renamed the variant database, and it was published online this morning. So we provide an update from the past 20 years of all 940 pathogenic variants that we know about across 3,400 cases of adrenoleukodystrophy. And as Joe and Stefan were talking about yesterday, note that this database is put together and curated really incredibly and single-handedly by Dr. Kemp. We are working to have the variant annotations match ACMG guidelines. So that's why we're starting to update the vernacular to make it sort of match the accepted guidelines for variant interpretation. And this is an effort that is really important for longitudinal follow-up of patients identified, especially early on, with adrenoleukodystrophy, because I think it's going to help us understand the genetics a bit more. And this is another way to help refine, maybe 3-4 years down the line, who should go into screening, who shouldn't go into screening. Are there subpopulations of patients with certain variants that may not need such intensive MRI screening or adrenal surveillance screening? I don't know the answer, but I think our data and data harmonization efforts are getting better. And the more we harmonize and the more we work together, the better we'll be at teasing out what things like newborn screening and the sequencing of these variants are telling us. And it'll tell us more about the biology of disease. So I'd just like to acknowledge everyone that's really helped me out over the years and made this whole enterprise sort of go. So I think we have plenty of time for questions, and I'm happy to answer as many that come up.
Thank you, Dr. Mallack, and congratulations on that publication. Congratulations to all the authors. Dr. Kemp just shared the link in the chat. Thank you for that. That's really exciting news for this conference. There have been quite a few questions. I'll do my best to go in order. So given the neuroplasticity of the brain, particularly in children, can intensive neural rehab such as OT, PT, speech therapy transfer skills to other areas of the cortex? We see this in adult neurological treatment with forced use techniques and mirror visual feedback techniques out of Australia. Is it standard for referrals to these types of therapies in symptomatic post-transplant children?
Yes, I think so. So the whole point of treating the boys with as early as possible is to halt the disease. And then any of the boys that develop symptoms, you essentially want to turn cerebral ALD into arrested, for the term is arrested cerebral ALD. You want to turn it into a static condition so that it's no longer evolving. And then any of the functions that are lost, focus, exactly as said, on recruiting other areas of cortex to take over some of those functions. Now, this is going to be patient to patient dependent because of the extent of the disease that may affect boy X versus boy Y, and the underlying wiring that's there. One of the other questions that I've gotten recently was, well, in the area where there's damage, can we regrow cells or recruit cells to that area? To my knowledge, that technology is not anywhere near clinical use. There's a crass saying in biology, but unfortunately it's true, a dead neuron is a dead neuron. But the idea is the rest of the healthy neurons around that lesion, we want to recruit as much as possible to help retrain and relearn. So yes, there are, post-transplant, there are opportunities, I think, for boys to recover. And anybody who lives in pediatric neurology will tell you, children can be jaw-droppingly resilient. And that's what we always hope to see.
Thank you. That was actually Susan's question. She has her hand raised, so I'll go to her.
I think she's muted.
It's just a follow-up question, because in the research and the literature, it shows that there are multiple centers, especially for motor activity. So it's been shown with adult stroke patients that there is transfer to secondary motor centers. So that was kind of what I was asking.
It's a wonderful question, and you're right. And I think kids are at least as good at this as adults are, and some of us would probably argue that they're even better at it.
Right. Okay. Thank you.
Let me give you an example. There are patients with a bad form of epilepsy, an inflammatory form of epilepsy that takes over one whole cortex side of your head. And the neurosurgical technique is to disconnect the two sides of the brain or remove that hemisphere. And if you do that in an adult, you will make them hemiplegic. The one side of our bodies would not work. Children can be retrained to put all of that right-sided, at least motor function, over to the left side and regain strength and coordination on a side that shouldn't work. So in a lot of ways, kids are much more plastic.
Thank you. There were 3 separate comments/questions about the availability of the MRI goggles that you refer to. So, I mean, I know from personal experience that wasn't something that was offered to us where we monitor. But if you could talk briefly about, if there's a family that inquires about it and they find out that it's not being offered.
Yeah, so this is the program that we were sort of made aware about probably in the last, I guess I lost a year somewhere in here. I would say last 18 months, but we've really only started readily doing it. We did the first case, I think probably about a year and a half now, but we're only now readily doing it in the past year. And that was because this was an initiative put together independently by our neuroradiology department, because they do a lot of, they scan lots of kids. So the second I found out about it, I sort of learned how to implement it. It takes a good amount of, like I said, orchestration, but we've had some success with a couple of patients, and hopefully we're going to try to expand to everybody.
That's great. And I can comment too, just because, as I said, we're thrilled with where we're monitored, but unfortunately this wasn't offered to us. So I did inquire. I don't want to mention any specific company by name because I know there's a few that do offer it, but I have reached out. They were very nice to me and appreciated my connection with the ALD community. And they actually allowed me to see a demonstration of it at Sloan. They're so cool to see in action. I did try, I'm still trying to get it going at my center. I know the machines are costly, but I'm happy to talk to anyone offline about my research into it. And, it can't hurt to ask, you don't know until you ask. So hopefully that's helpful for those that were asking about it. If boys have delayed enhancement, do you increase frequency of MRIs or do you continue at the rate of every 6 months?
That's a very good question. So we didn't put guidance into the paper once the lesion is identified. The line in the paper is call one of us or call Jerry Raymond, and then but we what we'll most likely do is if there's a lesion and there's no enhancement, depending on the features, you may rescan the kid in a month. I wouldn't go longer than 3 months, but do close MRI follow-up. One of the things I didn't mention in some of the new data that we put out is we've seen in a couple of patients in the data set where their first MRI has evidence of enhancement. You repeat it, the enhancement's gone. And then you repeat it again 3 months later and it's back. So that tells us a little bit about the early pathophysiology of disease, that in a lot of ways, when you transplant a patient, and I think this is also seen in the gene therapy trial, there's some variation in the enhancement after treatment. We see some of that sputtering in the onset as well, which sort of makes sense. What it means, I don't know. Will it happen every time? I don't think so. It only happened in three out of the 40, I think 40 some odd kids that we have the enhancement data on. But it's just something to keep aware of. But you're going to want to monitor really closely thereafter. So I wouldn't wait till 6 months. 3 months would be max for repeating the scan. Some places would probably even do it a month to 2 months thereafter.
Okay. I may have missed, what age are these boys with enhancement? I would imagine they are a teen and or adults who on first MRI have lesion that will never have enhancement.
Yeah, so the initial new data that I showed was kids that we limited to kids that were 13 and under. We just tried to focus it in the sort of highest risk group. There is a publication that we put out a couple of years ago now on the adult lesions with cerebral ALD. They most often are non-enhancing and they appear stable for years. They do require some degree of monitoring, but I don't think there's any major consensus around that. There is a research piece that's been put out, a consortium, an international one run by Dr. Englund, where there's general guidelines around all aspects of ALD, which is, I think it's that paper's still under review. But we limited this data set initially to boys under 13 to keep it focused.
Okay, Dr. Pierpont says, really awesome work. Of those patients followed pre-symptomatically in your analysis, what was the range of less scores at time of treatment? Also, just because their NFS score is 0 and they are asymptomatic, it doesn't mean there are no neurocognitive or behavioral symptoms.
She is exactly right. And I think for the whole cohort, they were treated with a median less score of like 2 or 2.5. The cohort that was treated, where if you cut it down to just the boys that have a less score less than or equal to 1, I think the treatment less score was 1.5 or 2 on median. And we comment on that in the paper.
Okay, great. For boys with cerebral ALD, are there any concerns if they should develop, quote, long COVID, end quote, even though vaccinated, that there might be a neurological impact? It's a great question.
I don't know. I would say in general, and I think Molly was touching upon this. We had a meeting early this morning. Patients with, and this is non-specific to ALD, patients with chronic neurologic disorders who become infected with any sort of seasonal virus or bad viruses, their neurologic symptoms can get worse. So for example, we have our epilepsy patients, and if they get a bad virus or an infection, they start seizing more. The headache patients have more headaches, that sort of thing. I don't know enough about long COVID. I don't know that anyone knows enough about long COVID yet to sort of answer that question. But I will echo what Molly says, especially because this is a patient population that develops adrenal insufficiency, which puts them at higher risk for more severe infections in general, that the patient should really consider being vaccinated when they're able.
Thank you. There's just one other question that's not specific to neurology, but I'm going to read it because I know there are a lot of new families on today, and we've had a few responses in the chat, but just to acknowledge it. As a parent, how are we notified of the particular ABCD1 variant that our child may have? Is this provided by the genetics test lab?
I'll say how it works in New York. In New York newborn screening, they do the ABCD1 variant testing once you sort of pass the first 2 tiers. If for whatever reason that doesn't happen, you get referred to a metabolic geneticist who then does the genetic testing, and those results are provided. And then if you somehow make it to me, I'll do the genetic testing. So at least in the New York system and in our sort of local community, there's multiple backups. Someone's going to do it, and someone's going to get you those results.
Sure. I can say too, I just for us and our family, I always try to consider our pediatrician kind of like our first go-to. So we were lucky in our case, it was faxed to her. So once we asked for anything that she received, we were able to get it. And then of course, reaching out to your care team in the ALD world above that, I think would make sense. I lied. I'm going to ask one more and then we're going to get to Dr. Raymond. We always put you in the hot seat, Dr. Mallack. At what point do we recommend vaccination? I'm assuming for COVID post-transplant.
Oh, that is a good question. That's a question. Are there any transplanters on the call? Maybe I saw Dr. Orchard. That has to do with how immune reconstituted you are, and that's a little bit outside of my depth.
I think that's the BMT team makes that.
Yeah, that's a question.
And I would also say, I think it's an individual BMT decision, because I take care of children who have been transplanted at different centers. And my experience this year has been that there have been different recommendations from different centers. So I think that it's whatever the center that you're getting your transplant done in is what you follow. And that's for all vaccinations, not just COVID, because you also have to get revaccinated for other things too.
Interesting. Thank you so much.
My pleasure.